Our next speaker is Helen Terry. Helen's the Director of Policy, Public Affairs and Research at Crohn's and Colitis UK, and is going to spend some time telling us about the work that she's been doing on designing patient-centered services. Helen, you're very welcome.
Okay, and thank you very much for asking me to come and talk. I'm hopefully bringing the patient perspective here today. Okay, so my talk then is about improving patient outcomes and experience. And actually what I'm going to be talking about is a project that we're running in Scotland at the moment around designing patient-centered services. So I'm going to start with a question. I've only got one question in my presentation, but I think it's fundamental to what I'm talking about. And I have to say, listening earlier, I was a little bit disappointed in the numbers of people that voted for involving patients as a really powerful way of driving up quality of your services. So my question is feedback, consultation, or co-design. At what point is it most useful to engage with patients to redesign services to better meet their needs? So we've got right from the start. Or maybe when you've formulated some ideas and you want to take some ideas to a forum maybe to discuss them with patients. Or actually when you've got some proposals that you want to put out there and seek feedback or views on. Or maybe leaving it to various ways of eliciting feedback on the services that you're providing at the moment to look at ways that maybe you could be improving those. Okay, so time to vote. Ooh, I thought that said 100% for right from the start there. But actually, that is pretty high. I'm really encouraged by that. In a way, I can maybe go away because probably you've already got the message across, but I'm talking about a project where we're actually involving patients right from the start in co-designing services in Scotland. For those of you who are not familiar with the concept of co-design, probably you all are, but this is a process where professionals empower, encourage, and guide users, in this case patients, to develop solutions for themselves. And the key word here that I would pick out is partnership. It's about equal partnerships, bringing people together to work together to develop solutions that actually have the patients right at the center of those solutions. This is a project we've called Better Care for a Better Life with IBD, but it's a program for improving the quality of care by co-designing and implementing new approaches to the management of IBD in Scotland. And we're really fortunate to have the support of the Scottish Government in this. They're actually part funding this project, and they work very closely with us sitting on our steering groups. So it's a multi-stakeholder collaboration, which is actually led by Crohn's and Colitis UK, but what we're trying to do is coordinate IBD quality improvements across the whole of Scotland. Very important is ensuring that what we're doing aligns with the Scottish Government's priorities, and we're looking at good local initiatives and how we can learn from those and disseminate them across the whole of Scotland. Research also comes into this because we also want to promote collaboration and engagement with IBD research across Scotland. So this is the framework, starting from the bottom with pilot working groups, and we've got 2 pilot working groups at the moment in Scotland, one in the Highlands and Islands and one in Glasgow. And those 2 were chosen really because they're very different types of services. Highlands and Islands, very diverse, scattered population, as opposed to quite an urban population in Glasgow. So we're co-designing by service mapping, looking at service redesign, and then actually all the learning from that will be fed through a national multi-stakeholder steering group into a pan-Scotland delivery plan that we're looking to develop by next year. So this is now drilling down and looking at the pilot structures. And those pilot groups involve all the stakeholders in their IBD services. So it's clinicians, nurses, GPs we've got involved as well, psychologists we've got involved, dietitians, pharmacists. And also really important is the relationship that we have with the health boards, because we had to have those health boards on side really when we started doing this, because their support is going to be absolutely fundamental in enabling us to then then pilot some of the initiatives that are coming through from that. So we're going on a little journey now up to Inverness, a beautiful, beautiful place to be, and looking at the work that we've been doing in the pilot in Highlands and Islands in Rakemore Hospital. So this is where we started. We brought everybody together in a room for a day. We brought a roll of paper and we rolled it out across the whole room, and we had post-it notes. Not very technical, but actually it worked really, really well. And we had everybody moving around post-it notes. There were some things that maybe the patients were prioritizing that the clinicians felt should go somewhere else, and we all came up with this at the end of the day, a consensus on what patients and clinicians felt were the problem or the challenging areas that could be looked at in terms of service improvement. And this is what we came up with. Okay, so all of those post-it notes were condensed down into here and actually grouped under 5 different areas in terms of symptoms, diagnosis, ongoing care, relapse, inpatient care, and discharge. At the same time, we actually ran a survey through Crohn's and Colitis UK on our website, encouraging patients across the whole of Scotland to input their views into this national survey. This is just one, this isn't really relevant, the question here, but I just wanted to show this survey because we had nearly 800 patients inputting into the survey. And what was really encouraging was that it actually replicated the issues that had been identified through the patient journey mapping that we were doing in Highlands and Islands and Scotland. So it gave us reassurance that we were potentially on the right track with some of the work that we were doing. We're now at the implementation stage. We've done all the planning. So this is again looking at the pilot in Highlands and Islands, and there's a lot of information there, but I just wanted to bring this up so that you could see that this is now being condensed down into 8 different work streams. And for each work stream, there's a plan, there's a description. Outcomes, it's very important that we're actually measuring what we're doing to define quality improvement, how we're going to measure things, and actually what is going to be done at each stage. So just to go very quickly through the work streams. Work stream 1 is around early diagnosis, and in particular there, the potential for greater use of fecal calprotectin. Work stream 2, fast-track referrals and rapid access to IBD services. Work stream 3 is all around the IBD multidisciplinary team. 4, ascertaining our population. Again, that's already been mentioned, I think, this morning. 5, maintaining care. 6, dietetic service provision. That was something that came out very strongly through the patient mapping. And 7, guided self-management and peer support. So those are the areas that we're currently working on in Highlands and Islands, gathering information from testing out small changes sometimes and looking at the effect that that's having in terms of quality improvement. So where are we now? We're now just about to publish phase 2, a phase 2 report from the project, but what's interesting and I think is particularly relevant to today is that information technology and infrastructure and software development relating to IBD care has been identified as a significant aspect of the project and any proposed Pan-Scotland delivery plan. So I just wanted to put this up. I know that Kath is going to be talking about My IBD portal. This is actually a patient portal, but this is now being rolled out in a few sites across Scotland as one of the initiatives that we're going to be testing and evaluating. I'm not going to say too much about this because Kath will be talking a lot more about that in a minute. But I did just want to talk about another one that's being trialled in Highlands and Islands. This is Professor Angus Watson. Is he here today? Oh, that's a shame. Okay. Professor Watson is actually on the pilot steering group in Highlands and Islands and also the national steering group. You can't actually read his pledge there, but he actually held up his pledge card, and Angus is pledging there to improve the quality of IBD care for patients across Scotland. And one of the ways he's doing that is by developing a mobile app. And I think this is quite interesting, and I don't think there's anybody in the room that would disagree with that. There are more mobile phones in the world now than there are toilets. Even I've got one, and that's saying something because I'm a bit of a technophobe, but I have a mobile phone. I actually have a smartphone, even better. Okay, smartphones and IBD. Really, this was developed by Angus to meet some of the specific issues in Highlands and Islands, particularly related to the population that they have to look after there. So as I said before, it's a very dispersed population. Actually covers 40% of the landmass in Scotland, but there's lots of sort of remote care that's needed to ensure that those patients are kept in touch with their services when they need to. So this app has been developed and patients are enabled to enter daily data based on Harvey Bradshaw and the Simple Clinical Colytic Index, via a mobile phone. So they're supplied with a mobile phone, those that haven't got one, and they can enter their data daily. And that data remains anonymized until it crosses the NHS firewall, but patients can also use this to message through this particular app. So this is just a snapshot really of what the app looks like. But actually, patients can use this using a smartphone or a tablet or a PC. Okay, and this is how it works. So again, tablet, PC or smartphone, enter data, which then crosses the NHS firewall in Scotland and then can actually be viewed in clinic by, in this case, it's the IBD nurse. And this is an example of the dashboard that the nurse actually sees to help her manage the patients that are using the app. So each day she or he can go in and we'll see red alerts, amber alerts, or no alerts detected. But this is a good way of flagging up to the nurse which patients are actually needing ongoing attention. And this is just an individual record for the patient so that you can see they're recording pain, well-being, bowel frequency, both day and night. And we've been holding various focus groups to test how patients and staff actually find using the app. And patients are really enthusiastic and very supportive of this. And they actually have said to us that it's actually transformed clinical encounters. They actually feel quite reassured by being monitored. So this is, in a way, a tool to aid self-management and give the patients the confidence to enable them to do it. But actually, the staff were very, very positive about it as well. They felt that it was very easy to integrate into their day-to-day delivery of healthcare and that it was actually very easy for them to use. So next steps for the app is to actually work on linking to the Scottish Electronic Patient Records, looking at integration with the IBD registry and aligning the data set so that data can be sort of pulled between the two. Also data flow to ISD and HARES data. Possibly in the future linking with the IBD portal that we're going to be hearing more about in a minute, and looking for region-wide adoption and developing an online peer support group, because again, in the feedback, that was something that the patients were saying that they would really value. Okay, I'm not going to go into any detail at the moment, but I did say that what we're working towards here is the development of a pan-Scotland delivery plan, and we're not waiting until we've finished all the work to do that. We're already starting to populate that plan. And how we're describing it is measured against the IBD standards, and also the second column there is the policy framework in Scotland. So we were aligning all work about with the standards, the policy framework, and it's about taking the standards forward in Scotland. Why we're talking about it here today, I'm very passionate about it. It's a really exciting piece of work for us, but it is Scotland. I do think, though, that there are lessons that we can capture and learn from this work that potentially could be rolled out across the UK. And also, I think that we've got a model here that's potentially an exemplar for other long-term conditions. And certainly working with the Scottish Government, one of the reasons why I think they're so enthusiastic about this work is that they can also see potential there by working with us to actually implement this across other disease areas. So all it remains to do is thank you very much for listening.